about challenges of organizing home care, wound care in England, regional perspective. Alison.
Thank you very much for the invitation to speak. It's been very interesting to be part of this project. I always like speaking last because it means you can adapt the presentation to link in with the previous speakers, and hopefully it will generate some discussion as we have time for that this morning. So within the UK, the home care model is not really that unusual now. We've been heading towards that and delivering that for many years. But just to give some perspective on that, but also the challenges of where we are and how we link to the policy makers, I think is the thrust of my presentation this morning. I'm not just repeating what was in the document. You can read that for yourselves. So it's sort of more of a reflective piece about where we are, and it links very much to Georgina's presentation around life perspective and the need to look at prevention. So healthcare funding in England, so we looked at NHS England because NHS Wales, NHS Scotland is a different way of working, and I work within NHS England. And so the model comes through taxation, and in the last year or so, the model of healthcare has changed considerably, and I wonder how it is changing a lot across Europe, and some of the challenges we face may be similar. So now we have what is called clinical commissioning groups for a borough. I work in Tower Hamlets in East London, where EWMA is going to be next year, just to say. So just along from there. We have clinical commissioning groups, so they are basically given funding from NHS England for their borough, for their population. And so for me, that's 250,000 residents. And so this clinical commissioning group is led by general practitioners, the GPs of that borough. And that's a considerable change. It's led, so the push within England is around commissioning of services by clinicians. And so these are given to the money for the services is given to local providers, and they may be the acute hospital trusts, they may be community healthcare providers. Many now are joined, they're acute and community providers. There are also independent providers, and there's charities and voluntary groups. So the clinical commissioning groups make the decisions about how the money is spent. And that's quite a change from 5-10 years ago. Within England as well, there are prescription costs, but otherwise care is free at the point of delivery, unless you go through the private route. One of the key challenges that we have, and I'm sure this must be the same in all the countries, is that wound care is not a medical specialty. And that means that expenditure on wound care isn't generally known in the boroughs in which we work. The expenditure is not ring-fenced, and a patient can be seen with a wound through multiple departments, specialties, and across all areas in acute and community care. And when we did a review of the wound care in England, we realized that provision is historical. So in all those areas, really, it's what has happened for many years. And it may be focused very much on the personalities of the people working in that area, what they've pushed for, what they're passionate about. And so different regions and different boroughs will have a slightly different emphasis. However, within England, wound care is delivered by key people, and that's primarily the community nurses. That's another word would be district nurses. Practice nurses, for us, that's nurses within the GP practice, and so they care for the mobile patients. You've got foot health departments, podiatry, tissue viability services, and then you've also got dermatology departments, plastics, and vascular. Those would be the key areas, as well as, of course, the therapists that work, but they don't deal with the wounds themselves, but they're working with patients in a holistic manner around wheelchair services and so on. But it seems to be still a bit of a lottery. We describe it as a postcode lottery for patients as to what standard they get. They may get quite a basic standard across England, but whether they get excellence is definitely a bit of a lottery. So how do patients access this service? One of the key areas may be etiology. So a patient presents maybe at their GP's or their practice nurse, and if it's an unusual etiology, they may be sent to dermatology or vascular or plastics, but otherwise the care is provided, and if the wound is non-healing, then they may get to see other people. So duration is often dependent on local referral criteria and the facilities that they have for dealing with someone with a more complex wound. But also, sometimes it's dependent on that patient's persistence, unfortunately, to get to the specialist that they require. And they may have to work quite hard at enabling referral to go ahead. One of the key areas, though, for patients is whether they're mobile enough or mobile at all. And so that may be, say, put a boundary around who they see. If they're immobile and at home, that would be district nursing. If they're mobile, they can get to their GP practice. That would be a practice nursing. We'll see them. The problem we have is that if we're very strict about that, that means that the skills required may not be there. So in England, the practice nurses don't generally manage people with leg ulcers. They may be a very mobile patient, but they're seeing somebody who doesn't necessarily have the skills to manage them. And so there is a growing conflict within England about who should be seeing these patients and who is funded to provide that care. And that's an interesting area, and again, it will depend on the discussions locally. There are no real guidelines about that, except, of course, we have guidelines around leg ulcer management. So it seems obvious that the persons that should be delivering the care should be those with the skills. And then there may be specialist clinics as well, and again, that's determined locally. There may be diabetic foot clinics. That would be quite commonplace. But there may be tissue viability specialist clinics as well. But I suppose when you look at wound care, it seems to be quite a reactive service. Georgina talked about the life perspective. And one of the things that we need to grapple with as healthcare costs are spiraling out of control is the issue of prevention. And wound care primarily seems to be a waiting for a complex wound to arrive. We're waiting for referral, say tissue viability. If your referral criteria is the wound must be non-healing for 12 weeks or something like that, are we just waiting for that wound to get bad before they finally see someone who can deal with it? And so the issue of having a system of care that links into prevention far more effectively than it does is a real one. Georgina's talked about evidence-based delivery, and in the UK we do have guidelines, and locally there are referral pathways. But one of the key areas that is struggling within England are the community nurses. District nurses across England are struggling because of capacity, because of the number of patients now seen at home, the early discharge of complex patients into the home. And if our wound care service delivery relies on the district nursing services in particular, putting the care into effect, then we have a problem. And district nurses, there is an awful lack of capacity, and the number of nurses qualifying within community nursing degrees now has gone down. So we do have a critical issue within England, and you may be able to translate that to your place of work. And there are areas where evidence is not implemented. And again, if we're looking at the evidence base for the care that we should be putting in, we do need to look at some of the things that we're not implementing. And one of the key things I always think that nursing does not implement is the enormous amount of evidence there is around ankle range of movement and the effect of inactivity at the ankle on venous ulcer healing. So whoever is drawing together the venous ulcer guidelines, if you're doing that, you know, I just find it frustrating that we work within our silos. Nursing does the wound care bit, the topical bit, and the compression bit, but there's so much evidence that we do have that we don't use. But implementing is difficult, and again, you're relying on a workforce that is depleted with an increasing number of people with comorbidities and the complexities that they have, that we can't fulfill the requirement of delivering the amount of care that we need to provide. So another thing, if we're talking with policymakers, and if you think about the clinical commissioning groups, or for you, who funds your service, the problem is that expenditure is not often known. And the big costs are all in different pots. So you may have a bit in district nursing, a bit in tissue viability, you'll have prescribing costs, you'll have something in physio. And so for the detail, for the people making the decisions, they don't have the detail they need to be able to make decisions. And so we have to help them with that as well. And there are some prevalence studies in England that have been useful, and often is quoted the amount of millions that are spent on wound care. One of the areas that we do have, but is not always used in England, is the prescription data. So that's actually quite easy to obtain. We can find out how much is spent on different dressings and all the products, including dressing packs and so on. So that tells a bit of the story around the type of activity that's going on and the variety of products that are used. Sometimes, of course, the variety is enormous, and that may be the push to try and get a formulary that is more succinct. The other data that is increasingly being used is admission rates, particularly for cellulitis. But unfortunately, the data is only as good as the people putting it in. And the admission data can be a little spurious and is difficult to rely on. However, that is very, very important data, especially if, again, we're looking at prevention and care at home. We're trying to avoid admissions. And within England, there is an enormous push about avoiding admissions. So if we're trying to, again, change someone's views about what should be provided, giving them data on the admission costs and the money that's being wasted is very, very valuable. In England, we have a massive focus on pressure ulcers, and so data is being collected around the country on pressure ulcers. The Tissue Viability Society has been very prominent in that, in trying to make sure that the data collected is valuable, and that we're all talking about the same type of data, that we're collecting the same data. And that's been a big piece of work with the Department of Health as well. We also have what is called sequin payments, and sequin is about commissioning for quality innovation. And all trusts may have fines in effect, that money that is for innovation. If you don't do it, if you provide poor or substandard care, then in effect there's a fine and they lose money from their budget. And that has focused people's attention on standards of care, especially around pressure ulcers and falls. One of the key areas that is lacking, and this was in Sebastian's talk as well, around needing to collect data, is that we don't have wound registry locally or nationally. And this is a key problem. So for diabetes, we know the prevalence for diabetes and heart disease and all these key areas that people know fully how many people they've got in their population. We don't have the same for wounds, and it's something that we need to tackle seriously if we're going to have the data we need for the expenditure. But times are changing, and across Europe we have a bit of a crisis regarding money. And the commissioners now pay for services. And so whilst it's lovely that we talk about what is a good standard of care, and we talk about guidelines, and we all have a heart for improving people's lives, the thing is somebody is paying for that service, and they need to know what they're getting and why. And we have the challenge of trying to articulate what that's about and why we think that this service, this wound service, should continue or develop. But are we speaking the same language? We're striving to improve patients' lives, and commissioners would say the same, but they are struggling with the money that they have. And if care is based on historical developments, it's just the way it is. Do we just continue to provide care within those boundaries? Or should we be challenged to look afresh at the service delivery? And we have to just, instead of being blinkered, we have to see the bigger picture and think how things are looking from the other side of the fence. And as we look over this cliff, some of us are walking still towards it and we don't know we've got a cliff. In England, 2015-16 is considered incredibly significant for healthcare funding. Everyone doesn't know what's going to happen. So if you want your service to continue and to develop and say, but surely we should be putting more into this because it will save money down the line, then you have to be able to articulate what that is, and you have to help the people that pay for the service to have a vision for what that looks like. How do we save the money? Because in the UK, we have to find £30 billion in 2015-16. I've no idea if that's possible. I've no idea what will happen, but we do have a bit of a crisis on our hands, and I know other areas in Europe do as well. So just saying we need to have this very nice service isn't going to give us the money that we need to provide it. So what's the challenge? No? Oh, that's it. Okay. So we have to understand who's paying for the service, and we have to understand where they're coming from. And we have to be part of a transformation rather than just a transactional change. We can't just tweak things. We have to see the bigger picture and see how we can support the commissioners in their aim to provide a service for their community. So we have to align our service to their strategic aims. And if you don't know what their strategic aims are, whoever pays for your service, if you don't know what their aims are, then you need to read the supporting documents, because it would be out there somewhere. And we need to know what our value is, and we need to be able to articulate it. And the interesting thing about the word value is that value is very subjective. And we talk about value-based care, But my values may not be someone else's values. So we have to make sure that we're saying the same thing, that we understand where we're coming from. And so what does the service look like? We have to deliver services that tackle the population. We can't just go on doing what we've always done. We need to look at the big outcomes for that population, not just how many people we see in a clinic, or how many people are healing within 12 weeks if we're ignoring a whole swathe of people who we don't know about. We have to get the data for the whole of the population. And fundamentally, again, within England, the drive is about prevention. Commissioners of services are being pushed by the Department of Health, by the government, to focus far more on prevention. We spend in the UK about 4% on prevention in healthcare, 4% of the budget. They recognise that this isn't enough. So if the Commissioner's goal is about prevention, then how can we develop our services to make sure that prevention is at the heart of the services? How can we also say we're interested in what you're trying to achieve, and so that we start to speak the same language, that we hook some of our developments onto their aims for prevention? And so we've got primary prevention, we've got early detection. How can we change the structure and the model to include an earlier detection of the problem? You know, small wounds become big ones. How can we get there an awful lot earlier? We need to have a key focus on reducing admissions. And so cellulitis, infection, deteriorating pressure ulcers, the reasons for admissions we need to focus on and put a cost attached to that. And we do need to focus on productivity. And it was interesting that in the document we talk about the increasing number of unqualified staff being used. And that's very short-sighted. And we have to be able to articulate why that is short-sighted and not the way to go. That actually, if you're trying to save money, then seeing a specialist early is the way to go. And somehow we also have to, as senior leaders, is to bring the money together into one pot, at least so that the GPs or whoever is funding your service can understand where the money is and where the leaks are in the system. So we need to integrate some of the funding. And we absolutely need to do some tracking and registry of wounds and benchmarking, at least within ourselves, within our boroughs, so we've got year-to-year comparisons, or hopefully comparing it nationally. But we're nowhere near that in England, and it is a sense of frustration. The Tissue Viability Society have tried to look at national audit data for wounds, not just pressure ulcers, and so the work continues on that. So we have a challenge on our hands, and I would just look at your service and think of all the things that you do, what has the biggest impact on outcomes for patients? And I suppose, you know, if we were starting with a blank page, what would a service look like now? I know what we've got, but what would we do differently if we had a blank page? What would be your vision for a good wound care service, delivery, and design? And will this reduce expenditure across the population? Because if it doesn't, then no one's going to want to buy it, however nice it is, because there isn't the money there. That's the situation in England anyway. So we have a challenge on our hands, and so I've tried to just move it from just about the wound care model into how we articulate that for policymakers. So welcome your discussion.